Hello, my name is Jorge Cortez. I'm the director of the Georgia Cancer Center. We're going to be talking today about particularly the role of the FLT3 inhibitors in the management of acute myeloid leukemia. These are my disclosures. It is very clear that for many years we didn't make any progress in the management of patients with acute myeloid leukemia, certainly not in the older patients, and in the younger patients, perhaps the improvement in survival is more reflective of the use of transplant and other supportive care measures. And that is because not much of the treatment had changed for many, many years. However, perhaps the biggest advance that we had in AML during these years was the discovery of the molecular heterogeneity of the disease, where we were little by little started to identify different molecular abnormalities, which were important from the prognostic point of view, but also because it provided the incentive to look for targets for drugs that could affect some of these specific targets. And one of the first ones that was identified was FLT3. It was identified in grossly about a third of the patients with acute myeloid leukemia, more in subsets than in others, for example, more on the diploid. And because of the recognition that it was a tyrosine kinase, a receptor tyrosine kinase, it became a good target to try to develop therapies that would be effective against patients that had this disease with these molecular abnormalities. It was also defined very clearly that it carried a very poor prognosis. And here it's good to remember that there are two different possible molecular abnormalities or mutations in the FLT3, what's called the internal tandem duplication, which is by far the most common and has the worst prognosis that you can see here in yellow. And then the kinase domain mutation, most frequently in the DA35 residue, which has not such a poor prognosis and it's not nearly as common, but it's certainly not as good as not having any mutation in the FLT3. We know very well the poor prognosis that is conferred by these diseases in the frontline, as I was showing you earlier, but also in the salvage setting, it carries a very poor prognosis. In this series, for example, of a little over 100 patients that had diploid karyotype and had some of them had the FLT3 mutations or receiving first salvage, you can see how the overall survival for patients that have a FLT3 mutation is considerably worse than the patients that do not have a FLT3 mutation. And even in patients that achieved a remission after treatment, now this is a historical series, so they could have received a variety of different treatment options. But even if you just look at the patients that did achieve a remission, you see how the overall survival is much better for the patients that do not have a FLT3 mutation than for the patients that did have a FLT3 mutation. And of course, that follows very tightly with the duration of complete remission. So overall, this completes a picture of a mutation that confers a very poor prognosis, both in the frontline setting and in the salvage setting. Well, as I mentioned, these led to the development of a number of FLT3 inhibitors. And this is a kinome tree, which shows you the inhibitory activity against a variety of kinases by several of the FLT3 inhibitors that have been developed in the clinic. And we can divide them into two types, the FLT3 type 1 inhibitors, which work against both the active and the inactive conformation, and then the type 2, which only work against the active conformation. And importantly, what that means clinically is that they would work against the ITD, but not against the DA35. The type 1 would work against also the DA35, at least in the clinic. Now, each one of these red dots represents a different kinase that's inhibited by each one of the presented drugs here. And as you can see, some of them are very dirty drugs, like the Gilteritinib, which is no longer being developed, whereas others are very specific. For example, Quizartinib, which inhibits very few kinases. And it is debatable how important is that selectivity. We're going to be talking a little bit more about the clinic manifestations of all of these. I'm going to start with some of the earlier studies, and midostaurin was the ones that we still continue using today. The first one that was introduced in the phase 2 study of midostaurin as a single agent in acute myeloid leukemia was reported almost 10 years ago. And as you can see here, as a single agent, it has some level of activity, both in the FLT3 mutated patients and the FLT3 wild-type patients. You can see that at the bottom here with response rates in the 60 to 70%, but this includes mostly drop in blasts. You can see that PRs are very few and there are no CRs in this patient population. Sorafenib was also investigated initially as a RAF inhibitor, but we also know that it is a potent FLT3 inhibitor. And in this phase 1 study that we conducted many years ago, we identified that there was some responses in patients receiving sorafenib, AML patients heavily previously treated. Most importantly, nearly all of the responses happened in patients that had the FLT3 ITD mutation. So that showed that this could be a very active drug. And actually, for a while, this was the main drug that we had available for patients with FLT3 mutations because it had been approved for other tumors, never for acute myeloid leukemia up to this date. Now, the groundbreaking study that brought the first FLT3 inhibitor to the clinic today is this study called the RATIFY trial. This study was with midostaurin. It was a study where patients that had FLT3 ITD mutation, that mostly younger patients, were randomized to receive standard chemotherapy plus placebo or standard chemotherapy plus midostaurin. And the primary objectives of overall survival and event-free survival, as you can see on this slide, were significantly better for the patients that received midostaurin, with a 4-year survival, for example, being 51% versus 44% for the placebo-treated patients. And the 5-year event-free survival is 27.6% and 19.3%. So overall, very good results, and that made the approval of midostaurin, which we now have available in this patient population. The important observation here is that when you look at the different subsets of patients, whether the patients had a high allele frequency of the FLT3 ITD or a low frequency of the ITD burden, or a kinase domain mutation. Remember, I told you this is a type 1 FLT3 inhibitor. The benefit is seen across the board in all different subsets of patients. Of course, none of them reaches statistical significance just because of the numbers, but it clearly shows that trend of efficacy across the board. Now, I mentioned that sorafenib for many years was available, and so there are many studies that were done with sorafenib. And this is one that comes from Germany, where a very similar design as the one that I showed you for the RATIFY, where patients were randomized to receive chemotherapy alone, or chemotherapy plus placebo, or chemotherapy plus sorafenib, and then they could receive consolidation and maintenance. Now, the main difference is that all patients were eligible regardless of their FLT3 status, and actually only 17% of the patients had a FLT3 mutation. Interestingly enough, the event-free survival and the relapse-free survival was significantly better for the patients who received sorafenib. Why that is, it's unclear. So that is something that still remains to be investigated. The overall survival was not different for the overall population, but if you focus only on the FLT3 ITD mutated patients, you can see that there was a trend for a favorable relapse-free survival and overall survival for the patients that received sorafenib. Of course, because that represents a small subset of the patient population, none of these are statistically significant. But it again showed the potential benefit of sorafenib added to a chemotherapy, or more generally, a FLT3 inhibitor added to standard chemotherapy. Then came what we probably could consider the second generation FLT3 inhibitors. And Gilteritinib is particularly important because it is the second FLT3 inhibitor that has been approved, the first one in the Salvage setting. And you see this was based on this one study initially, which is a phase 1, phase 2 study, that in patients that had received prior therapy, you see that it induced an overall response rate of nearly 50% in the patients that had FLT3 mutation. The wild type patients, the patients with no mutation in the FLT3, had very low response rates. It also influenced the response rate whether the patient had received prior tyrosine kinase inhibitors or FLT3 inhibitors or not. But you can see that even patients that had received a prior FLT3 inhibitor still had a good 40% response rate, which is actually fairly robust. Not as good as the ones who had not received these agents, but it is still very good. That led to the development of this randomized study, the pivotal trial, which included patients that had received prior therapy and were randomized to receive, these were all FLT3 mutated. They were randomized to receive Gilteritinib or salvage chemotherapy, which was predefined at the time of randomization. And you see the options below here could be intensive or low intensive. And then the patients could receive transplant. And the results are summarized on this slide. If you see the CR rate was significantly better, the CRC, the composite complete remission that includes CRI and CRPs and CRH, also significantly better, and as well as the CR plus CRH, so partial hematologic recovery. But most important is that the primary endpoint, which was the overall survival, was significantly better for the patients treated with Gilteritinib. And by the way, so was the event-free survival, both in favor of Gilteritinib. These results, again, led to the approval of this drug for the treatment of patients in Salvage with Gilteritinib. And here you can see that the response, the outcome in patients according to the type of mutations they had, whether they had ITD alone or a kinase domain mutation alone. And you can see that the overall survival is better in both instances in favor of the Gilteritinib. The response rate is not that much different for the kinase domain mutations alone, but the overall survival is. Another drug that's being developed is Quizartinib. This is a type 2 inhibitor. And there was this initial phase 2 study that showed very robust responses in the ITD patients in the range of 50 to 60%. Most of them are CRIs, few CRs. And then there are, in addition, some PRs. Interestingly, some responses in the patients without a FLT3 mutation, but that's outside of the topic that we're discussing today. That led to a randomized study that's called the Quantum R versus standard chemotherapy. And you can see here at the top left that the overall survival was significantly better. The difference is small, but it was statistically significantly better. And also was the event-free survival in the bottom right. Now, this drug was not approved by the FDA in the when it was presented based on these results. And this slide summarizes the results. And you can see that the difference was larger for the Gilteritinib arm. And one of the arguments for not approving the drug was that the differential was very small against the control. Now, the populations are not exactly the same. They look somewhat similar, but for example, for the Quizartinib study, patients could only have a very short remission duration. They couldn't have a longer remission duration. And they should have received anthracycline-containing chemotherapy, and they could only have a FLT3 ITD. The Gilteritinib study, they could have received lower intensive chemotherapy, and they were eligible regardless of the duration of the first remission, and they also could have a kinase domain mutation. So not exactly the same patient populations, but importantly, they do. I think both studies demonstrate the value of FLT3 inhibitors. Certainly, Gilteritinib ended up being approved, and it's a good thing that we have it in the clinic. One important aspect is the issue of how much value does these responses having, and there's this analysis called the Q-twist that we did on the Quizartinib study, And you can see that it differentiates the survival into the time spent in toxicity, time spent in relapse, and then the time that is spent without toxicity or relapse, which is called the twist time. That's the valuable time. And you can see that in this Quantum R study, most of the benefit comes from these valuable time. Although there is some more time spent with toxicity with Quizartinib, most of the benefit comes from the time spent without toxicity or relapse, demonstrating a real benefit for the drug. Now, we do know that patients can develop resistance to these agents. For example, this is seen with Sorafenib, or with on the left, you see that there is a gatekeeper mutation, and the kinase domain mutations confer resistance to this type 2 inhibitor. And these mutations actually develop in up to 20% of patients treated with a FLT3 ITD inhibitor in the clinic. Now, the type 1 drugs can have some activity in vitro, but when you look at the results, for example, focusing on the left at the Gilteritinib data, the patients that have a kinase domain mutation may still respond to Gilteritinib, provided they still have the FLT3 ITD. If they only have the kinase domain mutation, the response rate is considerably lower. We also have analyzed many patients have FLT3 mutations, and they have other mutations. So the question is, what is the impact of having any of these other mutations? And you see some of the common ones here. And in all instances, Gilteritinib was better than salvage chemotherapy, whether FLT3 was commutated with any of these others. On the right, what you see is that there's really no difference between patients that, and on the right panel, you're only seeing patients treated with Gilteritinib. You can see that the response is about equally as good if they had a commutation of any of these commutations or they did not. We also know that the allele burden, the allelic ratio is important. Patients with a high allelic ratio do worse than patients with a low allelic ratio. But in both instances, Gilteritinib provides a benefit compared to standard chemotherapy. Now, one important thing that we've identified is that in terms of mechanisms of resistance to Gilteritinib, one of the most common is the emergence of additional clones that have other mutations. And here you see in red at the bottom of this panel that the most common is the emergence of RAS mutations. So that is a common mechanism of resistance. And you can see here what happens, that the clone that has a FLT3 mutation may start going away, and you start seeing the emergence of these alternative clones that have other mutations. So there are different clones. It's not like one same clone changes specifically. There have been preclinical studies showing that combining a FLT3 inhibitor with a RAS inhibitor may provide benefit when this happens. As you can see on the bottom part here, when you have these commutated with RAS, you see these purple lines represent co-incubation with a FLT3 inhibitor and a RAS inhibitor, and that provides additional benefit. So there's been combination studies, for example, with azacitidine in the clinic, with Sorafenib, with Midostaurin, and with Quizartinib, and you can see that the CRC may improve, particularly with Sorafenib, and even more with Quizartinib, as well as the overall survival. So clearly, combination therapy is where we are going in this context with these drugs. Very briefly, I will mention that other drugs may have good FLT3 activity. CPX-351, which is approved for secondary AML, seems to have particularly good activity against patients with FLT3 mutated clones. And this is just a retrospective analysis looking at showing that patients that have FLT3 mutations in this first salvage setting, if they have experienced prior FLT3 inhibitors, they have an even worse prognosis. But their outcome is much better if they receive combination therapy than if they receive single agent therapy. Again, this is historical data, but it again shows that combinations seem to be the way to go. So in conclusion, I think that these drugs have significant clinical activity in the context of FLT3 mutated AML, and they, for the most part, are very well tolerated. They improve survival. It's been shown, certainly with Gilteritinib as a single agent in the salvage setting, and with Midostaurin in combination with chemotherapy in the frontline setting, perhaps some with Quizartinib as well. We need to be aware of these mechanisms of resistance because alternative clone with other mutations emerge, which tells you that we need to go to combinations in the future. So I'll stop here and I thank you for your attention.